Walking pneumonia. Sounds mild, right? But some cases need hospital treatment, and doctors are seeing new challenges, including rising antibiotic resistance. Today we'll unpack Mycoplasma pneumonia, how it causes disease, how doctors diagnose it today, and the updated approach to treatment in 2025. Quick roadmap. We'll cover what Mycoplasma pneumonia is, who it affects, classic and unusual symptoms, how testing has changed, treatment choices, including what to do when macrolide antibiotics don't work, and practical prevention tips. Mycoplasma pneumonia is a tiny bacterium, unique because it lacks a cell wall, that commonly causes atypical respiratory infections and is a leading cause of community-acquired pneumonia, especially in children and young adults. Because it's cell wall-free, antibiotics that target cell walls, like beta-lactams, don't work. Pneumonia infections tend to cycle every few years. Since late 2023 and into 2024 to 2025, several regions have reported increased activity and cluster outbreaks, often in schools and dorms, likely because pandemic-era social distancing interrupted usual cycles. Public health surveillance shows variable regional patterns and concerning rises in macrolide resistance in some countries. Pneumonia attaches to the respiratory epithelial cells via specialized adhesins, damages the airway lining, and triggers both direct damage and immune-mediated inflammation. That immune response can explain why some patients develop extrapulmonary problems. More on that in a moment. Symptoms often start gradually: sore throat, low-grade fever, persistent dry cough, headache, and fatigue. Because illness can be mild, it's often called walking pneumonia. But some people, especially young children, older adults, or those with underlying disease, can develop more severe pneumonia requiring hospitalization. Pneumonia can also cause non-respiratory effects: rashes, joint pain, cardiac issues, neurologic complications like encephalitis, and blood problems such as cold, agglutinin hemolytic anemia. These are thought to be immune-mediated and vary in severity. Diagnosis is now dominated by nucleic acid amplification tests, NAATS, PCR. PCR detects the organism early and is more specific than older single-time point serology tests, which can give false positives or reflect old infections. Culture is possible, but slow and not used routinely. Clinicians still sometimes use paired sera, acute plus convalescent, to confirm infection retrospectively. But PCR is the practical frontline test in many places. Treatment has traditionally used macrolide antibiotics. Azithromycin is commonly prescribed, especially in children. However, macrolide resistance has risen substantially in parts of the world. In some countries, reported rates have exceeded 50 to 60% during recent surges, making macrolides less reliable in those settings. Clinicians must consider local resistance patterns and clinical response. Alternative options include doxycycline, a tetracycline, for older children and adults, and respiratory fluoroquinolones for adults when needed. In children under about 8 years, there's caution with tetracyclines and fluoroquinolones because of side effect profiles. That's why macrolides remain front line for young children in many guidelines, unless macrolide resistance or treatment failure occurs. If someone isn't improving after 48 to 72 hours of macrolide therapy, clinicians should reevaluate, confirm diagnosis, PCR, consider macrolide resistance, assess for complications or co-infection, and switch antibiotics if indicated, e.g. to doxycycline in appropriate patients. Severe cases may need hospitalization and supportive care. Corticosteroids are sometimes used in immune-mediated severe disease, but are not routine. There's no vaccine for pneumonia. Prevention relies on standard measures. Stay home when sick, hand hygiene, mask use during outbreaks, and early identification in institutional settings like schools or military barracks to limit spread. Example, a 15-year-old with a 2-week cough tests PCR positive for pneumonia. Azithromycin is started. After 72 hours, fever and cough persist. Local data show high macrolide resistance. Clinician switches to doxycycline and symptoms improve over days. Takeaways: Mycoplasma pneumonia is a common cause of atypical pneumonia, especially in young people. PCR is now the mainstay for diagnosis. Macrolides are first line in many settings, but rising macrolide resistance in parts of the world means clinicians must watch for treatment failure and switch to alternatives, like doxycycline or fluoroquinolones, based on age and safety. No vaccine exists. Standard infection control remains essential. If you found this useful, like and subscribe for more clinical updates. Have a question or want a script for a shorter 60-second explainer or infographic? Tell me in the comments. I'll make it.